On this call,
Recording in progress.
received an email from Eventbrite. We've had tremendous demand for this call. And so our friends at Vanderbilt asked if we would be able to record the call. We wanted to read for you. Faces and names are not going to be preserved, only the audio for this call. And so we are thrilled that there's been so much interest in this call. And we appreciate your understanding in that.
Yeah, so still feel free to ask any questions. There will be anonymity involved in terms of just the audio being extracted. So let's get things started. I just want to introduce myself. My name is Jahan Corbin. This is my buddy Lynn. We are both survivors. I'm about 5 years out. Lynn's about 6 years out with triple negative. And we are privileged to sit on the board of an organization called Breast Cancer Recovery in Action, which our acronym is BRA. And we're a 501c3 nonprofit organization based out of Middle Tennessee. And we offer support for anyone who's been affected by breast cancer in the breast cancer community. We have exercise classes, we offer nutrition and lymphedema education. And then the other part of our program that was really the most impactful to me personally is a curriculum-based support group where we are able to share our experiences. So they can't hear me.
Well, we're getting reports there is an echo on the call.
Okay, let me see if I can turn this.
Yeah,
Wait, can't hear me at all.
there we go. And better.
Okay.
Can you hear us now?
So what
somebody wave if you can hear us.
Can you hear us? Okay, so what I was saying is, please
go.
go ahead and mute if you don't mind. That just helps kind of get rid of some of the distractions in the background. And we certainly want you to unmute and ask questions when you'd like, but we encourage you to just ask in the chat first, please, so that Dr. Park will have the floor as far as the sound goes. So that's a little bit about who we are, what BRA is, and what we do. And now I'm going to turn it over to Lynn to introduce our special guest speaker.
Yes, I am honored to welcome Dr. Ben Park, who is director of Vanderbilt Ingram Cancer Center. He's a renowned doctor, very approachable doctor. And Jahan and I had the honor of having a pre-call with him. And during this call, I was able to learn that he is a fellow Midwesterner from Michigan. I hail from Illinois. And he attended the University of Chicago in my hometown of Chicago. So he's checking all the boxes for me. I planned to make a joke before this call. My good friend Jahan here is a rabid, and yes, I say rabid, Alabama football fan. So I was going to make a joke about how University of Chicago doesn't have a football team, but I'm like, I better Google that just to make sure. And they actually do have a football team. I have lived in Chicago my whole life, never knew this. And actually, they were one of the founding members of the Big Ten. So my question, Dr. Ben, is did you ever actually go to a football game during your years at University of Chicago?
No, it was not something like, a real Big Ten football game. But I used to have this T-shirt with the helmet of the University of Chicago. But by the way, the Bears stole that from them. It's the classic C. And it would say the University of Chicago Big Ten champs. And in tiny font, it would say 1899, 1900, 1901.
That's funny. Well, I do also know that you are a Lions fan. Your team's having a good season. They had a rough Sunday last week.
Well,
I'm
also a Ravens
suffering
fan.
who had a good week last week.
Yeah, it was tough. I didn't know who to root for since I lived in Baltimore for 20 years. I lived in Michigan for 17. So it was kind of a conflict there.
Torn loyalties.
Yeah.
But we didn't bring you all here to talk football. But October, as those of us in the breast cancer community know, can be a tricky month. There's a lot to deal with, a lot of pink ribbons, there's a lot of events. And so I invite all of you to just take a deep breath. We have a very well-respected physician here who I can tell you personally is very understanding, very empathetic, wonderful source of knowledge. So I hope this is a really wonderful hour out of your day. And with that, I would like to turn the floor over to Dr. Ben, not Dr. Park. Dr. Park is his doctor.
His dad.
Oh, his doctor, his dad. And I would like to just ask you to get us started by sharing a little bit about why you're so passionate taking care of breast cancer patients.
Thanks. And thanks for that generous introduction and kind introduction. I think my kind of foray into the breast cancer world really, like everyone really, was personal. When I was, I'm divorced now, but my first wife, her grandmother was diagnosed with metastatic breast cancer when I was training to be an oncologist. And that was really the first person who I knew and loved that had gotten the disease. And you have to remember also, this is 1997-ish. So we didn't have all the therapies that we have now developed over the past 2 to 3 decades. And it was really just chemotherapy at that point for her. And it was heartbreaking to see how her body just kind of withered away with each chemotherapy. And probably the biggest lesson that I learned from that experience was when she asked me, Ben, do I still have to keep taking chemotherapy? That really broke my heart, because I think her oncologist I'm sure he was a great oncologist, but he also wasn't listening to her and she wasn't telling him how horrible her quality of life was. And that really spoke to me. It's something I carry with me and remember, that it's really important for us as care providers to talk to our patients about how they're doing, because some of the therapies that we prescribe are really, really toxic. And so she actually went into hospice after that and really died peacefully and had a much, much better quality of life for the last few months. But that was really, really challenging, and ultimately made me realize that, I run a research lab, and I've been doing so since 2002, that treating patients is something I'm passionate about, and I want to help all people, but I'd love to put myself out of business. And that's kind of how I view working in the lab. If we can really find new therapies and cures for all types of breast cancers, then what a huge impact we could make.
Yeah. Love that. Thank you. Well, as you know, we've kind of prepared some topics of conversation, but we also open up the floor to your questions, and we've actually already had a couple come in from participants. So let's just get started with one that we got from Jennifer. I hope I'm pronouncing this correctly, but Verzenio is a chemo maintenance drug that some people take instead of a hormone blocker. And this person was told that someone would only have to take it for 2 years, that it cuts chances of cancer return by 35%, potentially more powerful than anastrozole. Is that true? How do we know? And should we switch? Is it better for our bodies for long-lasting effects? So if you'll just kind of address Verzenio, please.
Yeah, it's a great question. There's a little bit of confusion, I think, in terms of the information in that question, because Verzenio is also known as abemaciclib. It's a relatively new class of drugs called CDK4/6 inhibitors for breast cancer. Palbociclib, or Ibrance, was really the first. And Ibrance, Verzenio, Quiscali is the other one, called ribociclib. They're all been approved for metastatic breast cancer, that is estrogen receptor positive, HER2 negative, for a while now. In our drug development world, the way we typically bring drugs along and approved is that we first do it in metastatic disease, because we have to figure out, do these drugs work? And in metastatic disease, we take CAT scans and we can see it. And because we can see it, we can see if there's a response and it shrinks. And based upon clinical trials and statistics, a drug graduates and gets FDA approved, and we can then use it for everyone. Then we start to think about moving it into the early stage breast cancer area, where the goal there is to cure the disease. And so early stage meaning it hasn't metastasized visibly yet anywhere, like in the liver or the lungs. And so Verzenio, all 3 of these drugs have now been tried in big clinical trials. The first drug, Ibrance, which is the prototype of these, first one approved in metastatic disease, did not actually meet its endpoint, and so is not approved. It didn't show improvements in outcomes. And by improvements in outcomes, we have to follow patients year after year, decade after decade, to show that the group that got the new drug versus the group that got placebo, there are less recurrences. That's our kind of signal that this works. And it prolongs lives, that more people are cured. And so Ibrance didn't meet that metric. There's probably many reasons for that. Verzenio, abemaciclib, did, but in a very high-risk population, meaning you had to have at least stage 2 disease, again, estrogen receptor positive, HER2 negative, and not in lieu of endocrine therapy, which is really the backbone and mainstay of our curative paradigm for this group of patients. It's in addition to it. And so most women will get, and men who got breast cancer will be prescribed 5 to 10 years of endocrine therapy if they're estrogen receptor positive. For higher risk women, we will now be able to offer, or have been offering, basically 2 years or up to 2 years of Verzenio. This is not an easy drug to take for many patients. It can lower your blood counts, but probably the most troublesome side effects is diarrhea. So much so that sometimes it's just not worth taking anymore. And so I put plenty of patients on it, and I always tell them, let's try it. If you can tolerate it, we'll go with it. But if not, we'll have a conversation about whether it's worth it. It's not 35% better. It's really, if you look at the absolute percentage points, it's anywhere from like 3 to 7% improvement on, and that's absolute improvement on cure rates. In this country, that's enough to get approved, because early stage disease, we're talking 3 to 7% is tens of thousands of additional lives that are cured every year by doing that. And that's really the name of the game. We're trying to improve upon cure rates. What we're really doing is treating microscopic cells that are left behind after surgery or or radiation. Not everyone's going to have that, but the higher the stage, the more likely you will. So stage 2 and stage 3 patients have more disease. They usually have lymph node involvement. And that's what puts them at higher risk, that they have these microscopic cells floating around in the body. That's why they typically get chemotherapy, endocrine therapy, et cetera. And now we can add to that common kind of armamentarium by giving Verzenio, again, if tolerated. My kind of take on that, like I said, it's definitely worth trying, but I also don't like tell people you have to take it, because I think the absolute value of this is relatively small. And if the quality of life, you know, I'm fond of saying this, if the treatment that we're giving patients is worse than the disease, then I think we have to kind of take a step back and reevaluate that.
Mm-hmm. Yeah. Thank you. Part B of Jennifer's question was, it sounds like, does Verzenio or any of that class, does it help prevent any of the hormone blocker related osteoporosis, or does it have any effect on that at all?
Does not. So the only class of drugs that we have that really do that, where we use it for breast cancer, are drugs called bisphosphonates. And so Zometa or zoledronic acid is one of them, and the other one is called denosumab or Xgeva. These are drugs that pretty much stop the bone from being destroyed, for lack of a better word. I think many of us think of bone as this static organ where it's just like cement. But in truth, bone is always remodeling, and we have new bone being built up and old bone being destroyed. And so as we age, and particularly in women, because estrogen is such a strong, powerful bone builder, and postmenopausal, that goes away. And so in women, there's usually an imbalance, and again, even in men as we get older, where now there's more bone being destroyed than there's new bone being built up. And so these drugs are actually drugs we use to prevent that. We also use them in metastatic bone lesions to strengthen the bone so the bones don't break from metastatic disease. But that's really the rationale behind it. Verzenio does not really touch that.
Okay. Thank you.
Okay. All right. So we have one more question that had come in before the Zoom started, and then we're going to hit the question that came in the chat. So this question came in from Janine. Regarding alcohol, especially wine, I know there is data out there that shows it's unsafe for former breast cancer patients to consume any form of alcohol. We also hear that a little bit every now and then is okay. I've been watching so much this month on programs, articles that state consuming wine is not good. So I'd really like to know your opinion, experience, knowledge on this topic. Any data studies that you have seen as to just how much, and that's in capitals, alcohol can contribute to recurrence? And this we hear all the time.
I know. And part of it is also, there's no one great study that we can turn to that says, aha, this is the answer. There's little studies here, there are little studies here. In the past, some of those studies have suggested that maybe a glass a day or wine a day is okay, just like I think what the question was outlining. And more recently, I think people have kind of said, well, if we look at the totality of all of these studies, probably no alcohol, period, is the best. And that's for both preventing breast cancer or other cancers in general, as well as even recurrence. But I got to tell you, I think one of the things that we all have to do is when we think about this is recognize that you have to live your life. And the incremental increase that we sometimes see and sometimes don't is a personal choice. I would argue that some of these small increases in risk, you're probably at higher risk just getting into your car and being at risk of being killed by a crazy drunk driver than necessarily getting breast cancer from having a glass of wine every now and then. Do I think you should be drinking, 3 glasses of wine every day? Of course not. And there's many reasons beyond cancer risk because of that or for that reason. But I do think, look, I have a beer pretty much every night. During the pandemic, I started having 2 beers every night. My wife called me on it. I've stopped doing that. But to me, it's really about you got to enjoy your life and you got to kind of take back your life if you've been diagnosed with cancer, which is really what BRA is about and how challenging that is. Not living in constant fear and trying to do everything possible to make sure that this never comes back. I think we all understand that, but at the same time, I don't want anyone to be miserable and give up your life if you really enjoyed that. So it's all about relative risks. And I would tell you to have a conversation not only with your oncologist or your physicians, but also with your family members and your friends and see what is right for you. So I don't necessarily condemn or condone having a glass of wine a day. I really have these types of conversations that I'm telling you. It's really what you're comfortable with. And again, for me, that's my personal choice that, a beer a day is okay for me. But yeah, probably the data now shows, yeah, if I gave up drinking altogether, maybe that would be even better. But then I think about, well, is it worth the extra 2 years that I may live longer versus enjoying the past 50 years where I've enjoyed a beer a day? I don't know. That's my personal choice.
Yeah. Could I ask a quick follow-up question?
Sure.
Actually, I had a survivor ask me this recently. There have been a lot of advances in genetic screening. Do you think at some point, or have you heard anything in terms of advances in like identifying, will genetic testing be able to identify who's at more risk for the connection between alcohol and breast cancer? Is that like going to come someday? Because it seems like maybe some people might be at more risk in that area.
Great question. My answer is a little bit biased. I'm trained as a cancer genetics person. I really believe in DNA and the power of genetics. So my quick answer is yes. I do foresee a day where we have so much knowledge about individual genomes, as we call them. We just don't have enough of that data right now. Even though we have hundreds of thousands, you think about the trillions of people in this world, maybe it's more than that, I don't even know. That's what kind of level of data we need to really start making connections about, hey, if you have this variance, is what we call them, in a given gene, then plus this variant and that variant and that variant, then you might be at more risk if you're, developing this disease, that, and the other. Even then, nothing is 100%, as I think we all know. And so environmental influences, things that we don't necessarily even take into account, living in a certain zip code, maybe that means there's a little bit more radon there in that neighborhood. Again, we just don't know. So nothing's perfect, but certainly I think the idea that we can learn and predict risk with a lot better accuracy from our DNA and our genes is in some ways already here, but coming down the pipe even more. I mean, I think we all know about the BRCA1 and 2 genes. There are many more now that we know about that you can be tested for. And if you happen to have one of those, yeah, you're at increased risk for developing breast and other cancers. And that, I think, is just going to start expanding and exploding as we go forward.
Oh, thank you.
Okay. All right. So we've had several questions come in from the chat from you all. So let's just start there. We have a question, Dr. Ben, from Onita. It says, I've had a couple of reconstruction surgeries with implants. The side where her radiation was has not responded well. And the plastic surgeon is referring her to Vanderbilt for a possible deep flap. Can you speak to the risks associated with this procedure?
Yeah, again, I probably have to defer that question to my surgical, plastic reconstructive colleagues. But I think with deep flaps, kind of in general, for those who don't know, that we take the flap, it's deep epigastric I can't remember, something perforating. What that really means is they take a chunk of tissues and they will actually can rehook up vessels. and then reconstruct the breast. And whenever you do surgery, there's always risk of infection, no matter what type of surgery. I think with flaps and grafts, one of the other risks that are potential is that when you manipulate the vasculature, and especially the microvasculature, especially when you're rehooking up tiny little arteries and veins, there's a risk of clot, and that those things could actually necrose the whole graft because you've lost the blood supply. But again, those risks are probably better discussed with the reconstructive surgeon, as well as the radiation oncologist, in terms of how radiation may affect the side that's getting reconstructed. And again, that is something that is known, but it depends on the type of radiation, depends on the type of reconstruction, et cetera.
Okay. And just for what it's worth, Onita, I'll just say that Lynn and I both had deep flat. And so if you talk to your reconstructive surgeon and you decide that's what's right for you, I'll put my email in the chat. You're welcome to reach out to me if you just want to talk to somebody who has had that procedure done semi-recently. I'd be happy to share my experience, but obviously talk to the physicians about the risks and your other questions. So
yeah, we can speak to patient experience.
Yeah.
And Onita, if you need a hand trying to get an appointment with one of the reconstructive surgeons here, I'm happy to help out. Doctors Perdikis, Bukovic, and others are ones that, I refer a lot of patients to them. So I've gotten to know them well over the last 5 years I've been here.
Yeah, we both had great experiences at Vanderbilt. Okay, next question in the chat. Can we talk about recurrence when tamoxifen became ineffective? What's the protocol?
Great question. So my guess is what that means is that someone has had a recurrence while on tamoxifen or took tamoxifen for 5 or 10 years and then came back. There is no set protocol. It really does depend on the situation, particularly if a woman is pre or postmenopausal, because tamoxifen really nowadays is used mostly in premenopausal women, and there's a number of reasons for that. But we have other endocrine therapies called aromatase inhibitors. Some of you are probably familiar with that. And they work very differently than tamoxifen. And so when someone progresses on a drug, we usually do not want to use the same drug because, they become resistant. There are some weird exceptions to that, which I could go into later. So the typical thing, though, if someone is recurrent with metastatic disease, we would put them on a different endocrine therapy that could be one of these aromatase inhibitors. And then we probably also, depending on the degree of disease, like how much, sometimes the age and how the patient's doing, is also use one of these CDK4/6 inhibitors that I mentioned, of which Verzenio is one. So again, we have ribociclib, abemaciclib, and palbociclib. And all of them really seem to work well in that area of recurrent metastatic disease. Palbociclib is more recently been kind of criticized because when they looked at the gold standard of overall survival, there didn't seem to be much difference. I will tell you, I think the statistics on that are a little bit flawed, or at least a little bit colored in some sense, because they are imperfect, meaning that in that study, when they looked at long-term survival and who was there and who was not from their disease, the problem with this was that, one, many people in the placebo group were allowed to cross over once the study was blinded. And so that kind of taints the data. And then two, they lost a lot of follow-up data. And so I will be honest with you, among the three, palbociclib to me seems to be the best tolerated and seems to have like the biggest bang for the buck in my experience. And many of my colleagues feel the same way. So I have not written off palbociclib because of that. It is still a really good drug. And for many patients, literally, they've been on it for years with metastatic disease and have not had progression. And again, this is when they recurred, again, on tamoxifen. They're premenopausal, they recurred many years later, and then you put them on palbociclib in this case, and letrozole, which is an aromatase inhibitor. And I've had some patients literally go year after year after year without any progression. So it's one of those things that we can't predict well, but we know that can occur. So we have those types of drugs at our disposal now.
Well, great. We have another question about kind of a similar topic about letrozole may not be as effective in overweight postmenopausal women with hormone positive, HER2 negative. What are your thoughts on that?
Yeah, again, there's a lot of kind of suggestive literature out there, but if in our kind of rule book of statistics, none of them really meet that metric to say this is a definitive study and finding. So I would argue that those types of data, which I have seen in studies, are more hypothesis generating than actual proving. And it's hard to know because we do see that there are drug to drug differences. Again, abemaciclib versus ribo versus palbociclib, they have as a class the effect of lowering blood counts, and that's what we monitor. But then only abemaciclib has this diarrhea, and only ribociclib has this thing with heart conduction. So it's possible, but I don't know how real that is in terms of the obesity and lack of effect. There have been many biologic rationales to say not just letrozole, but all the aromatase inhibitors may not work as effectively in obese women because the main source of aromatase, which is an enzyme in fatty tissues, is, well, I just said it, the main source is fatty tissues. And so the idea would be that if you have less fat, then you would have less aromatase, and therefore aromatase inhibitors would work better. Has that ever been biologically proven beyond a shadow of a doubt? No. But again, that's where all these kind of suggestions come from.
Great. I'm interested in your thoughts on any promising treatments in the metastatic setting, particularly for triple negative, ADCs, CRT, other?
Yes. So triple negative metastatic breast cancer, I think, as we all know, is a kind of the most aggressive type of breast cancers that we have, and historically has been associated with the fewest treatment options, which was just chemotherapy. That has really changed now because we have a number of new drugs. Immunotherapy is actually approved for first-line triple-negative breast cancer if the tumor expresses a certain protein above a certain level. And then the ADCs, as someone mentioned, that stands for antibody-drug conjugates. So this has been a real boon in our ability to treat patients effectively, but hopefully with minimal side effects. So the first one was approved with something called sacituzumab govitecan. I don't know who names these things. They're really crazy. And what it means by an antibody-drug conjugate, it's an antibody, which is just a protein, and then conjugated to that protein is a chemotherapy. But the chemotherapy is inactive until that antibody-drug conjugate hits the cancer cell and gets internalized. We think of this, or we call it, a Trojan horse strategy. So in the case of sacituzumab, it binds this protein that's on the outside of many cancer cells, not just triple-negative breast cancer. And so this is why it's now been studied and I think approved now for even non-triple negative breast cancers and even bladder cancers and other cancers soon to be. But it just wants to hit something on the top of the cell that will then internalize that whole ADC. And once inside the cell, there's an acidic environment that will kind of unlink the chemotherapy and it blows the cells up from inside out. That's why it works so well. It can have some side effects because once that cell blows up, that chemotherapy can start leaking around in the body. The second one that came about, which many of you probably have heard of, is in HER2. So this was originally approved just for HER2 positive breast cancers because the antibody, that protein component, is exactly the same thing as Herceptin. That's the drug we use, the first drug we use for HER2 positive disease. But instead, now it actually has, again, this chemical linker, and it has a whole bunch of chemotherapy molecules attached to it. And it's inert until it gets inside the cell and blows it inside and out. So it's not really attacking HER2 per se. And even though it works in HER2 resistant disease, so if they've gotten Herceptin, Perjeta, a bunch of other drugs, it can still work. The reason it works is because it's not those cancer cells that once they're resistant, they're not really relying upon HER2 anymore, right? They somehow bypass it because we were pummeling them with anti-HER2 drugs. As long as that HER2 protein is being expressed, the antibody drug conjugate doesn't care. It just needs it as a front door. So it goes in there and then blows up the cell. So because of that, we had the bright idea. It's like, hey, since it doesn't really rely upon HER2 signaling, maybe we can use it for non-HER2 breast cancer. And many triple negative breast cancers, even though they're HER2 quote unquote negative, will still express a little bit of HER2 protein. And so it was tested in triple negative as well as hormone receptor positive, that is also HER2 quote negative or low, as we call it now. And sure enough, it works. Again, it's one of those few instances where the scientific rationale made perfect sense and it actually translated into real clinical benefit in trials. So many times when we have great ideas in the lab, something happens and we're like, how come that didn't work in the clinic? but this time it actually did, and it's been approved. So now we have 2 antibody drug conjugates for triple negative breast cancer. We have immunotherapy, and we have more molecules like that on the way. Also, don't forget, if one has a BRCA1 or 2 mutation and has triple negative breast cancer, particularly BRCA1s tend to get triple negative breast cancer, we now have drugs for those patients. So that's another drug for a subset of triple negative breast cancer. So suffice it to say, there's a lot more drugs than just chemotherapy now. And we still have a lot of clinical trials testing these new agents, including, someone mentioned in that question, I think CAR Ts, that's chimeric antigen receptor T cell. That's a new form of immunotherapy that has worked remarkably well for hematologic cancers, meaning leukemias, lymphomas. We haven't had the same success yet for solid tumors like breast cancer, but we are slowly getting there. And one of the things that I'm doing is building up that capacity here at Vanderbilt Ingram Cancer Center to really become, the leaders on the forefront of using CAR T therapies for solid tumors like breast cancer. So suffice it to say, stay tuned. A lot of exciting stuff coming up ahead.
Can I ask a quick follow-up on again? So I actually talked to a lot of triple negatives because I had that, which did not progress, fortunately. How long do you think it'll be before the statistics begin to reflect these new technologies? Because I think, those statistics can be pretty grim. And so those patients are like, oh my gosh. But I'm like, well, there's a lot in the pipeline, the world has changed.
There's a lot.
I think maybe the numbers don't always reflect that.
That's exactly right. The numbers reflected in the trials, and that's how they get approved. But usually it takes, 5 to 10 years just to get adoption. So, that's another problem in science that we call dissemination and implementation, because the ability, and someone once said this to me, and it's really true, every time we have a success with a new therapy being FDA approved, it instantly creates a health disparity, and so really the well-resourced, well-knowledged can get to the new therapies. They can come to, state-of-the-art care facilities, and then people in rural areas or in areas that are, under resourced, they don't get that. And that's something that we're trying to be very cognizant about from the beginning, not like after the drug's approved, but nowadays talking with pharmaceutical companies and saying, we got to think about, okay, if this works, how do we make sure it works for everyone? How do we get access for everyone? And so that's where even just getting the knowledge out and getting access to new therapies can take up to a decade. It's probably better now, but that's what historically how long it would take. And so then you start to see the needle moving as, this becomes widespread adoption of standard of care. But we got to do better. And so that's why, again, another real area of expertise that we and many other centers have is this in implementation sciences, as we call it. How do we actually get the best testing, the best drugs immediately or close to as immediate as possible to all the patients, not only in Tennessee, but across the United States, if not the world, and then make a bigger impact faster that way. You think about it, what keeps me up at night, we have all these great new drugs and all these great new tests. How many people are dying prematurely because they just don't know about it?
Yeah.
So that's what I call democratizing oncology care, or in my case, precision oncology care. We just got to do better.
Okay.
Yeah.
Thank you.
I love your heart on that. It's encouraging to think about there being new therapies, but don't ask me to spell that one drug. I would lose all my money if I was in a spelling contest. Okay, next question. Could you talk a little bit about the use of the breast cancer index to determine benefits of different durations of aromatase inhibitor therapy, like 5 versus 7 versus 10 years? We get that a lot too.
Yeah, I get it a lot too. And, I have a lot of good friends and colleagues who work for the company that makes the BCI test. For those who are unfamiliar with this, when one has hormone receptor positive breast cancer, 5 years of therapy, endocrine therapy, which is a pill one takes every day, was the standard of care. And it still is. But newer studies came out that if you follow these patients on, and these take decades, right? Because now we're asking these patients to take 10 years, and then we have to follow them another 5, 10, 15, 20 years down the road to see if extended endocrine therapy, as we used to call it, is actually better. So it turns out as a group it is, But when you really look at the data, there's only a small percentage of patients that seem to really benefit from 10 years. And that's always been the question, well, who are those? Because we don't want to subject patients to these types of side effects. And some patients don't have any, but many have some, and some have a lot. And so we want to make sure that we're doing everything we can, again, to make sure the treatment's not worse than the disease. So this test came out that will take the tumor, examine it, and to say, okay, you should be on 5, you should be on 10. The truth of the matter is that the data they have is good, but in my mind, it's not definitive. And definitive data is really something that in our business we call randomized controlled trials that are prospectively carried out. Most of the data right now is still retroactive or retrospectively evaluated. And so my hope was that by the time when I landed here 5 years ago, I would tell patients, my hope is in 5 years, we'll have enough data that this will be prospectively validated, which is still not there yet. And so I think a lot of it is still maybe using that test, using other factors. Certainly, I think if someone's stage 1, 10 years of therapy is probably not going to be indicated for most patients, because that's kind of, I think, overkill, especially if they're having symptoms and side effects. And there seems to be 2 real phases of the impact of endocrine therapy. There's the first 2 to 3 years, which is probably the biggest bang for the buck. And then there's this 5 to 10 year phase, which I think is where a lot of cells lie dormant. And that's probably what's going on is in those patients who have those cells lying dormant, when we take it off after 5 years versus 10, we do see a difference. So again, it's a small subset of patients. I don't know if you are familiar, there was a study published by a friend and colleague of mine from Dana-Farber recently, and her area of specialty is young women with breast cancer, particularly women who want to have children still, which is a very challenging area, as you can imagine, for breast cancer. But we've always counseled women who want to have children, let's just do 2 to 3 years of tamoxifen and then have you get pregnant, conceive, and then we'll put you back on without any real data. It was, again, just the gestalt of looking at past data. And so she did the randomized trial prospectively and showed, in fact, that was safe to do. There was no inferiority of outcomes if women took time off after 2 to 3 years of tamoxifen to conceive, deliver, and then get back on. So that also reaffirms that probably the 2 to 3 years are the most important parts of the endocrine therapy. But thankfully now we have data that we can tell patients you can safely come off that, conceive, and then get back on it. Sorry, that was a long-winded question. The truth of the answer is we don't really know about 5 versus 10 with any definitive clarity. But I certainly talk to patients about that. If they want to, we'll order the test. But I like to make sure I'm honest with them and tell them, you know, we don't know for sure. Because I've had some women say, you know what, if you tell me I need to take another 5 years of therapy, I'm not going to do it. And then why order the test?
Right.
Right.
Okay. Well, this next question is sort of a spin on the previous question. My oncologist recently ordered a breast cancer index. I was told that this test where I approved my cancerous breast tissue was removed during a double mastectomy from 6 years ago and send it to a lab to see how it looks. My oncologist will get the results within 7 to 10 days, where I will find out if I should change off tamoxifen. Any opinion on how this examination of old tissue shows results? So I think the old tissue is really the key question here.
Yeah, you know, it's probably okay at 6 years. The real reason for this question is that we know that when you take any tissue out, including tumor tissue, we have to embed it in paraffin, and then we do what's called formalin-fixed paraffin embedded. So that's what actually the pathologist then takes to cut slides, do stains, and look under the microscope. That process with time will degrade the tissue, both the proteins and the DNA and the RNA. And so these tests are largely looking at RNA as what we call gene expression. And so that can get degraded. And so this is also true when we do DNA sequencing for tumors. The older the specimen, the more likelihood that the nucleic acids are degraded. The good news is all of these tests will have internal kind of controls, meaning that there'll be some genes that they'll look at. And if they're not hitting their mark by a quality control standard, then they'll say, we can't run this test. So I think it's still okay to try it and do it, but people just have to know that when it's older than 5 to 10 years, the likelihood of degradation goes way up, and that test may not actually be feasible anymore.
Okay, fair enough.
Okay, moving on to another kind of test. The next question is about the Oncotype test for recurrence. Some doctors say it's needed, some say it's not needed. What say you, Dr. Ben?
I have evolved my thinking on this over the years. Oncotype really came out to address a very important question. In the old days, pretty much any woman who had a tumor greater than a centimeter that was ER/PR positive, HER2 negative was a candidate for chemotherapy. And yet we knew that the vast majority of these patients would have good outcomes without chemotherapy. But similar to BCI tests, how do you know which is which? So they were really the first to put on the map of using gene expression, again, taking the tumor, looking at the RNA, and figuring out, can we categorize low, intermediate, and high risk? And more importantly, rather than just saying, oh, you're at risk for a recurrence at 5, 10 years, can we do something about that? Meaning, does chemotherapy actually change the odds and make it more likely that you will actually not recur? And so that was approved, again, initially retrospective. What they did was very clever. They looked at clinical trial specimens. So it's the next best thing you could get, because these were clinical trials that were prospectively randomized controlled trials that happened to save all these tissue samples. And so they said, well, wouldn't be any different if we did it today and we would just get the samples. So they looked at this, developed their algorithms, and then they had separate clinical trials where they did a validation cohort, as they call it. But then they did the real difficult test of what we call a clinical utility study of a prospective randomized controlled trial, particularly in intermediate risk groups, because they didn't have enough samples and patients and the prospective part of the statistics to say, what do we do with this intermediate group? It was very clear the high risk group were high risk. They should get chemo, they'll benefit. The low risk, do not give chemo, they don't get any benefit. But the vast majority of these cases were actually, in fact, intermediate. When the test was first being brought out, the notion really was discover what you don't know, because there were occasionally so-called, bland-looking tumors by the pathologist that were high risk by Oncotype and vice versa. And the thing was, oh, you don't want to miss those. Turns out those are probably really rare, and there's sometimes non-biological explanations, like, oh, it turns out there was just too much normal tissue that they cut, and that's what diluted the high-risk recurrence score into a low-risk recurrence score. Moreover, as those studies prospectively, looking at the intermediate risk especially, and then node-positive women, developed, matured, and were published, and these studies take decades, right? You got to think about how this is done. You got to just wait. Do women recur or not? And so it took a long time, some of which were just reported a couple of years ago, but now we have those data. It turns out the vast majority of women, if they have intermediate risk recurrence score, are not actually going to benefit from chemo. So we are now sparing probably 70% or more of women that we used to give chemo not to. And my thinking has evolved, because now I feel more comfortable when I look at the parameters that the pathologist says, which is standard of care, and what Oncotype says. Most often, they're very, very similar. In fact, colleagues and I at Hopkins developed an algorithm that you could predict the Oncotype score based upon the pathology staining. So I always have a talk with patients. Okay, here's what your pathology looks like. It looks so low risk that if we were to order Oncotype and it says high risk, would you really do chemo? Because remember, no test is perfect. And that's the question that I always start off with. Is a test going to influence your decision to get chemo or not? Because conversely, we may get a situation where a woman says, you're right, no test is perfect. I want to do everything possible, including chemo. Again, why order the test? That's the first tenet of medicine. Don't order a test if it doesn't change your management. So it really begins, I think, with a conversation with a medical oncologist and the patient saying, here's what we know of your risk. Here's what I think the Oncotype could or could not help with it. And this is what, we should talk about. Do you want to order the test or not? And so most of us nowadays, we're kind of looking at the pathology parameter and saying, this is a little bit iffy. Maybe we should order this. Or if we have a node positive patient who's postmenopausal, being node positive kind of instantly elevates your risk. But the great thing about Oncotype is that we say biology trumps anatomy. in the node positive oncotype study, if you had 1 to 3 nodes, you were eligible. And if you were low risk, you did not benefit from chemotherapy. So now we're even not giving chemo to node positive patients postmenopausal, which again, when I was starting this business 25 some years ago, that was unheard of. Everyone with node positive disease got chemotherapy. But again, we're not doing anything except exposing them to toxicity. Where Oncotype also did it, and for full disclosure, I became friends with these guys. They were super smart. They did this right. If you think about these types of studies, I always think there are a little bit of conflict of interest with the company because the company doesn't necessarily want to prove or disprove that their test is going to work, because if they disprove it, they've just lost their product, right? So they always just wanted to do the right science and the right test. So that actually happened to them. So the node positive premenopausal population, every one of those patients, except for 50 years and older, benefit from chemotherapy. So if you're premenopausal, less than 50 node positive, we don't even order that test anymore. We just said, you're getting chemo. That's what the data show, unequivocal. In fact, our guidelines now say don't order that test if it's a node positive premenopausal estrogen receptor HER2 negative breast cancer patient. They should get chemotherapy. Does that all make sense? That was a long-winded answer, but I'm a fan of Oncotype. Mammoprint's another one. I think Oncotype has more validated long-term data. There are two camps to that, but this is where I grew up with this. I know the data. I'm very comfortable with it. We participated in the trials when I was at Johns Hopkins. And so this is, for me, kind of the gold standard.
Great.
Oh, it's great.
That's great.
Anything to decrease number of women getting chemo.
Right.
Absolutely.
Right.
We would have gladly passed.
Yeah.
Okay, so I'm not sure the next question is in your area, but we will throw it out there. What is your opinion on proton therapy versus traditional radiation therapy? I have ER/PR positive, HER2 negative grade 3. Double mastectomy is done, and radiation is my next treatment.
You're absolutely right. This is not in my wheelhouse. It's really the radiation oncologist. That said, again, just like the plastics, I know a little enough to be dangerous. Proton therapy, I do think, is really cool because it can spare tissue. The way it works, it'll just hone in and zap, if you will, just the areas that are being targeted. We don't have enough, to my knowledge, data to say it could completely replace, external beam radiation therapy, which is the more traditional or standard radiation. But for select cases where, it's a lower risk, generally speaking, as an example, when a patient has a lumpectomy, we used to traditionally say, oh, they need, full-blown radiation to make it equivalent with mastectomy. We've now got enough studies to challenge that in certain circumstances where it's super low risk, or if a patient is, let's say, in her 80s or his 80s, that the risk is really of local recurrence. And so again, being in the 80s, if you get a local recurrence in your 90s, you're probably going to be able to deal with that, and the patient's not going to die from the disease. And so those are the areas that are a little bit more in the gray zone, where having a radiation oncologist having a good conversation about what is the relative risk of radiation, because again, nothing we do is without some side effects, versus doing maybe a shorter course of radiation or proton beam therapy. That would probably be, I think, the most appropriate thing.
Thank you.
Great. We have about 10 more minutes, and we definitely want to be respectful of everyone's time. So we're going to try to move to these next questions with a little bit of a clipped pace. But with having said that, I don't want to minimize anyone's question. And this next one is a little bit lengthy, so just stay with me here. Women with ER positive breast cancer are at an increased risk for heart disease and dementia secondary to treatment side effects, surgical, medical induced menopause. There are a lot of researchers. Dr. Avram Blooming, author of Estrogen Matters, suggests bioidentical hormone replacement therapy is now supported for women entering menopause, and even supported for women having had ER-positive breast cancer. Are you familiar with Dr. Blooming's research, and what is your opinion on hormone replacement therapy?
Yeah, I'm unfamiliar with it, but I think most of us who have treated enough breast cancer patients and trained us would say, do not do hormone replacement therapy, especially if you have estrogen receptor positive disease or a history of it. The truth of the matter, we don't really know. And I'm certainly the first to admit that yeah, many patients who get on endocrine therapy have postmenopausal type hot flash symptoms, et cetera. And it can be pretty miserable. But my kind of response to that is we have 4 different drugs that we can cycle between and try. And many times patients will find, it's kind of like antidepressants. There's a whole class of what we call SSRIs, serotonin uptake release inhibitors, but they're different for different side effects for different people. And so I often will actually have patients take a different drug. In some fact, sometimes I will actually even have them stop the drug for a couple of weeks to see if the symptoms abate, and then we can restart a different drug. I think that we have options, and that's the main thing that I would put across. I do not think it is safe. I'd have to look at the research, but most of the times when people have brought articles like this, it does not cut muster in terms of the statistical design and numbers needed to really make any conclusive evidence-based kind of guideline on that. There are medicines now that we can use to actually help with hot flashes. They've not been studied in breast cancer patients, but they have been studied in postmenopausal women. So that's now an option, literally just approved a few months ago. And I do think there are some circumstances where, again, the treatment can't be worse than the disease. So sexual function, vaginal dryness, et cetera. We try to actually say, well, try to use an estrogen-free based regimen like for Cleanse, but it doesn't work for everyone. I've had enough patients tell me this. And so sometimes we bite the bullet and say, you know, there could be some systemic estrogen absorption from estrogen creams, suppositories, et cetera, but the relative risk is probably low. And so, you know, you got to have a good quality of life. And so sometimes we just bite the bullet and say, okay, but full-blown hormone replacement therapy, whether it's a estrogen mimetic or not, I will tell you, that's scary stuff to me. We've had history where when I was training in the 1990s, the thing for estrogen receptor positive disease was black cohosh. I don't know if any of you know, and everyone thought, oh, this is a great anti-estrogen. And then it turns out with more scientific studies, it's an estrogen, not an anti-estrogen, which is the last thing you really want to take. And so those are just, you know, a few examples where I think people are well-intentioned, but you got to have rigorous science backing up these claims. And usually when I looked at these types of things, that level of rigor isn't there.
Okay, thank you. All right, next question pertains to liquid biopsies.
Oh, my favorite.
Oh, good. All right. I tested positive on Guardant Reveal for ctDNA. It was prior to starting any therapy. Since then, I have tested negative with Signatera twice. What do you think about liquid biopsies?
Well, so if it's in the metastatic setting, that's something we do routinely. And we usually do more what we call the qualitative aspects, meaning if you find a mutation with the drug, that's what we're looking for. What Natera response is a little bit not this, but what Natera is looking at is early stage disease. Remember I was telling you about how stage 2, stage 3, you have more tumor, and therefore you have a higher likelihood of having microscopic cancer cells floating in your body. That's why we give chemo. That's why we give 5 to 10 years of endocrine therapy. We're trying to eradicate those cells, and we give it to patients based upon relative risk, because we know that there's also risk of taking those therapies. It would be great if we had a blood test to say who's actually cured and who actually has microscopic disease, because then you could tailor your therapy based upon those types of parameters. So my lab was, believe it or not, the first to really enter this space more than a decade ago at this point, back when I was at Hopkins. But we've also not taken any shortcuts. We've been very, very careful about building the technology and designing studies to really prove that these tests are as good as we hope they are. One of my colleagues and former, kind of mentor in this field, Dan Hayes, is often quoted by saying a bad test can be just as dangerous as a bad drug. And that's absolutely true. So Natera's test to me is a bit premature, both for colon cancer and now the other things, and other companies are following suit. It does not take much to get FDA approval. You need what we call validation. And they have validated that if you find a mutation in blood, that you probably will develop some sort of recurrent disease. Now, what we don't have is utility. Can we do something about that? So if a patient does all their standard of care therapy and now has a positive ctDNA blood test, we don't know whether or not acting upon that and what to act upon that, how to act upon that is actually going to cure more patients or improve longevity. We're doing those studies right now. I'm in collaboration and partnership with a lot of colleagues across the country, but we do not have that information. So what do? I've had situations where patients have done this, it's positive, they do a scan, it's still negative. What do? Now you have a time bomb ticking inside of you that you think, and who knows what's going to happen. What's probably equally important, and if not more important, the negative predictive value of these tests are not that good. So getting directly to this question, a negative test does not mean you're free of cancer. And that's the other part that I think a lot of people are missing right now. And so the tests, in my view, right now are promising, but they are not ready for prime time. And that's my own personal professional opinion. But again, having been literally the first person to work in this space for breast cancer, I've talked to companies, sometimes they don't even understand what I'm talking about. And the number of DNA molecules you need to really call something negative, it kind of like, they look at me like a deer in the headlights. So stay tuned. I am really a believer of this technology, and I know we're going to get there, or I really feel we are, but now is really premature.
We're like so close on so many different fronts, it seems like.
Exactly. Yeah.
We have like 2 more questions. Do you need to hop off? What do you suggest, Dr.
Well,
Ben?
I can stay for 2 more minutes. Sure.
Okay, so we're going to take the last 2,
we'll take the last
and then we're
2.
going to cut it.
Yeah,
Okay.
and you did graciously provide your email address, so people could work with you via email.
We appreciate that.
Okay, the next question is, you said that you don't think that extended endocrine therapy may be beneficial for stage 1 patients.
Yeah.
Have studies shown that it doesn't benefit them? Also, how important is Ki-67, and can it change from biopsy to surgery pathology?
Yeah, so again, there's no great definitive long-term studies for any of this stuff, including stage 1. But, by nature of stage 1, what we do know, probably 95% of stage 1 patients are going to be cured. And so the relative risk of 10 years of endocrine therapy versus the benefit, to me, again, it's a personal choice. I've had some patients who are early stage and they're doing great on endocrine therapy, no side effects, and they want to continue. So I monitor their bone health and make sure that, the side effects are also not being too much. I'm okay with that. But again, I think in every patient, it's going to be a different, unique situation. And that's really where we do have to make healthcare personalized for every individual. I'm sorry, what was the second part of the question?
About the Ki-67.
Ki-67 is not as important as a single entity. It was for a very short period for that drug Verzenio in the early stage space, because FDA originally approved you could only get it if the Ki-67 was above a certain percent or 20%. For those of you who don't know, Ki-67 is a proliferation marker. So it tells us how fast the cancer cells are dividing. And there was hint that it didn't matter, but the Ki-67 low group in that trial turns out with time did just as well. So now we don't need it anymore. But it is one of the genes that's measured in different assays like Oncotype. And it does help me as a medical oncologist to try to get a sense of how aggressive a patient's tumor is. So I think it's useful information. It's actually not standard of care, believe it or not. So not every pathology lab will actually do it.
Okay, great. All right, and on to our last question, which is actually something we hear all the time. Collagen is suggested for a whole variety of side effects for people who have gone through treatment. And so the question is do you have any concerns for cancer patients taking collagen, any negatives? And I'm summarizing that question.
Yeah, it's a great question. And the reason I'm kind of sighing is because I can't biologically think of a reason why collagen would work or have side effects. So my kind of thought on that is, I guess it's okay if you don't feel any side effects for it. But yeah, it's just one of those hard things. It kind of reminds me of Claritin right now for bony pain for things like Neupogen and Neulasta, where there's a lot of anecdotal evidence out there. There was a start and stop about doing a real clinical trial, but people didn't feel it was worth it and it would be too costly. I was somewhat surprised when I came here that it's in our order sets every time we give Neulasta to actually also prescribe Claritin for bony pain. So I have patients who swear it works. I have also patients who say it doesn't do anything. So it's really hard to know, but I'm also like, it's pretty benign. It's just over-the-counter Claritin. So, try it and see what happens. And that's kind of how I feel about certain things like collagen.
Yeah. Okay, great.
Okay, very good. All right, last but not least, I'm submitting.
Yeah, BRA is sending out the
BRA is sending the email address for Dr. Park.
Yeah.
I was trying to put it down with everyone here, but this has been extremely helpful.
We so appreciate your time, Dr. Ben.
Yes, thank you very much.
Your dad did not make the call, but we're not disappointed.
All right, so we are so grateful to have all of you here, and if I can get to my
We're going
trying to find, sorry, let's see, share. That's not what I want on my desktop.
there it is over here. Here.
There we go.
Okay.
Sorry, technology, not my strong suit. Okay, so
I think you're muted now. I think you all are muted. We can't hear you.
Yeah.
There we go. Okay.
thank you.
Okay.
Well, you didn't hear her cursing in the background.
Yeah, never. You didn't miss anything. All I was gonna say, thank you for joining us. We're so grateful to you, Dr. Ben, and we wanted to invite you all to join us back next month. The November BRA Banter will be actually before Thanksgiving on November the 15th. It's always on a Wednesday from 12 to 1. It's free. We would love to have you join us next month. We're going to talk about managing stress and some of the emotional health components after experiencing breast cancer. So we would love to have you all back, and we just say thank you so much for joining us. Dr. Ben's email will be in a follow-up, so you can reach out to him, and you're welcome to reach out to either of us at any point. So thank you for joining us. Thank you for being here.
Yes, thank you so much.
Thanks all.
Have a wonderful day.
Bye.
You too.
Thanks. Take care.
Okay, bye-bye.